Comorbidities. So our last speaker for the panel is Dr. Lancaster. So Lisa Lancaster is an internationally known expert in interstitial lung disease and idiopathic pulmonary fibrosis. She serves as the medical director of the ILD program and IPF Clinical Trial Center at Vanderbilt University, and has served on steering committees of large national clinical trials. She served as a lead investigator on a large multinational IPF clinical drug trial. In addition, she conducts research in sleep disorders in IPF, in which she'll serve as an investigator to help enroll patients in the study and assist with the data analysis and interpretation. And so Lisa's really a expert in the comorbidities and keeping all the other organs healthy in idiopathic pulmonary fibrosis, and she's going to share that with us today.
So I'm going to take a very complex topic or multiple topics and try to break it down and help you understand how taking care of the rest of your body is going to end up helping you so much in the long run. And we're going to look at different statistics, and I'm going to try to break them down to reality and make them a little less scary as we go by. So there are a lot of different comorbidities in IPF and pulmonary fibrosis, and so what we mean by that is they're associated diseases that are more common in people with fibrotic lung disease. And so you see a whole gamut. We don't really understand the true prevalence of these, and they're probably more common just because of the age group of patients that have pulmonary fibrosis. Now, why do we care? Well, these comorbidities may be mechanistically linked with our pulmonary fibrosis. They may have a negative impact on survival if we don't take care of them. We may have mediators that are in common that are upregulated that may affect one disease and the other. One disease may end up being kerosene on the fire for another disease. We're beginning to understand genetics a little bit better, and we think of short telomeres as a sign of kind of premature aging of the cell. Well, it may affect other organs that also may be related to sort of a premature aging, such as reflux. Could that be sort of a premature aging of the esophagus? So we have an impact of having multiple other diseases on patients with IPF, and that's really true of any chronic disease process. The more other problems you have, then that may impact your survival. We want to take care of those other diseases. Well, why? Because those other diseases can also shorten our lifespan and take our lives. They also contribute to shortness of breath. So what we're doing is we're looking for any low-hanging fruit that can improve our quality of life and improve our shortness of breath with pulmonary fibrosis. So I'm going to start with obesity, and we've really focused a lot on let's eat right, let's get moving. This is the most common metabolic disorder, and it's really become epidemic in the Western world. We have lots of different foods and access, and we have lots of sugar out there, right? And it's all about taste, but we need to sort of reconfigure our taste buds to accept more natural sugars in fruits and healthy things. Think simple with that. Adipose tissue actually is hormonal and can have hormonal effects that can promote fat deposition, visceral fat deposition, which is linked with disease, and it can be pro-inflammatory as well too. When we gain weight too, we tend to gain weight under stress, especially with cortisol release around the middle, and that affects our breathing as well too, with a decrease, or sort of a pushing up of the diaphragm and a shrinking of the lung volumes. It's additive. So I tell patients when we look at their pulmonary function testing, I'll say, if we lose a little bit of weight, your vital capacity, your forced vital capacity, that main number we look at in pulmonary fibrosis, this is going to get better. So we can have some improvement, not fix it, but we can have some improvement in our lung volumes just by gradually losing weight alone and by gradually getting stronger with pulmonary rehab, because all of those maneuvers are force maneuvers and depend on your strength. We don't want to forget that there's really no true stability, that there is loss of lung function just from the age 18 to the age 85 of about 1,900 milliliters, or about 2 liters or so. So there is a gradual decline in lung function as we live longer. Other diseases and shape of our bodies, not just obesity, but shapes of our spine, contribute to reducing lung volumes as well too, and that's where pulmonary rehab can play a role, because they work on things that strengthen the upper body, those rhomboid muscles in the back that keep us standing up straight as well too. So we want you to get involved in good nutritional counseling, pulmonary rehab. Think about anything that your insurance will pay for, even outside of pulmonary rehab, silver sneakers, even just count your steps. Everybody's cell phone these days pretty much does that. Every 2,000 steps that you take is equivalent of a mile. And you start wherever you are and gradually work up with a goal. It's a high goal, but there's a sort of weight loss goal of 10,000 steps a day. And just scatter it throughout the day. The more you move, the better. So coronary artery disease is prevalent in pulmonary fibrosis. And if you look at the last bar to the right for significant coronary artery disease, you find that that is more prevalent in IPF than even COPD, which you think about those patients generally having a greater smoking history. Survival in coronary artery disease, when it's combined with fibrotic lung disease and with COPD, is lower. That's why we want to treat that and adequately manage that. See your primary care provider, take care of that cholesterol, do your regular routine surveillance for coronary artery disease, and stay active. That keeps the blood flowing, that opens up collateral circulation, and is extremely helpful to the body. We get clues about coronary artery disease just from looking for calcification. That's where those arrows are pointing. And sometimes we can even pick up calcified blood vessels on your CT scans. And so that gives us a clue to say, let's get you back to primary care, send you to the cardiologist, and risk factor stratify, get you taken care of. So we want to take care of all those risks that feed the fire or the kerosene on coronary artery disease, because not just affecting survival, it also affects shortness of breath, which may be an anginal equivalent. Some people, especially women, may not have classic chest pain. So off to reflux now. We worry about reflux as potentially being one of those kerosene on the fire for some people with pulmonary fibrosis. About half of healthy adults aspirate small amounts of secretions during sleep, but it's how you handle that and where it goes that's a problem, and whether or not your body is able to handle an injury pattern into the lungs. So even with acid that's been dropped into the lungs of animals, mainly dogs and rats, been able to show that that damage can get out to the pleural surface in about 20 seconds or so. So it's not just a proximal insult, it can be a more distal insult and perhaps connect with fibrotic lung disease. So when we look at patients with fibrotic lung disease, we are trying to look for anything, again, that's reversible that may be kerosene on the fire. We get clues from your CT. We found over time in studies that about 40 to 50% of patients with IPF have hiatal hernias that we can see. But the interesting thing is that most patients are asymptomatic. Evaluations for reflux can range from a barium swallow, which really has a poor sensitivity, to pH probe, impedance, and manometry, which do a better job. But again, they're a little more invasive testing and require some conscious sedation with that. So Ganesh Raghu looked at patients with IPF, and he had patients have a pH probe and manometry, and found that 90% of patients with IPF have reflux, but only 47% of those patients had symptoms. So the only symptom for some patients of reflux may not be the classic heartburn symptoms, but may just be cough. And that cough can be worse when you lay down nocturnally, and reflux may be worse when you lay down because of gravity as well too. So keep that in mind. Joyce Lee looked at survival in IPF in patients who were on proton pump inhibitors and found that in this retrospective study that was improved. So we have a lot to delve into when it comes to reflux. We have some initial data looking at Nissen fundoplications saying that, well, in general, they were well tolerated, but this wasn't powered to really see how effective it was in preventing the progression of disease. So stay tuned. Hopefully we'll be able to answer that. Lots of questions left. What's the cause and effect relationship of it? Is reflux kerosene on the fire, or does that happen because your pressures change as your lung volumes change in your chest? What's the best way to treat reflux if that's the case? So in general, I think you'll find varied opinions, but most fibrosis physicians recommend a low threshold for evaluating reflux. And certainly those patients who are going on to transplant evaluation, we want to know whether or not you have reflux and how well your esophagus works, because reflux has been linked with chronic rejection as well too. So sleep apnea, this one is important to me as a sleep physician as well too, because this is affecting 1/3 of your breathing during the day, and that's during our sleep. All sleep apnea is a floppy airway from the back of the throat to the upper windpipe, and occlusion or blockages or places where the airway can flop shut can be in various spots, but 90% of the time it occurs at the base of the tongue. There was an interesting study done in the mid-2000s where they took patients who had sleep apnea, they put them in an iron lung, which is a negative pressure ventilation that they used back when people had polio, left their neck sticking out, and varied their lung volume to see what would happen to that floppiness in the upper airway. And as they did that, they gradually increased the volume, and you can see as you move right, the volume increases. Well, as they did that, the little diamond for the apnea-hypopnea index, the number of breathing events or flopping shut of the airway that we count for sleep apnea, decreased. Also, the desaturations decreased. And part of that is that as we improve lung volume, we recruit more lung units and improve gas exchange with that. There are risk factors with sleep apnea that overlap with other diseases and comorbidities of pulmonary fibrosis that I've highlighted there. The symptoms are not necessarily going to be excessive daytime sleepiness in people with sleep apnea who are in the age range of 50 or higher. It just may be non-refreshing sleep, maybe fragmented, getting up and going to the bathroom multiple times that we usually blame on the prostate. 1 or 2 times may be related to the sleep apnea. Memory loss, concentration, even mood changes can be part of disrupted sleep. We look at airways, we look at neck size too in our assessment, because that can be somewhat predictive of the possibility of sleep apnea, as well as comorbidities that we just looked at. We know the prevalence of sleep apnea increases with age and plateaus at around 65 at about 20% or so. It may even be higher. When a group of people living in a retirement community who were completely independent in Spain in their 70s and 80s found a prevalence of about 80% with an apnea-hypopnea index of above 5. It's consistent with sleep disordered breathing. So it's probably higher than we think. We looked at 50 patients with IPF, and they all went through sleep studies and answered questionnaires. And out of that group, 88% had sleep apnea, and 68% had moderate to severe sleep apnea. Again, they were not necessarily sleeping, so it could be just disrupted sleep. So we worry about the dips in oxygenation that can occur with airway occlusion. We know that's pro-inflammatory. Is that egging on the process of any inflammatory disease or fibrotic disease? The stretch of the lung changes from when you have occlusion of the upper airway, shallow breathing spells, to an overstretch with hyperpneas, to shallow breathing spells, hyperpnea. So there's this overstretch, understretch as you go along during the night, which may be damaging more to the periphery of the lung. Well, that's kind of where we see pulmonary fibrosis. So we want to think about having a low threshold for evaluating patients with sleep problems so that we can pick up those patients with sleep disordered breathing or sleep apnea, get them evaluated, get them treated. CPAPs is not as bad as it used to be. A lot of the plastics are a lot softer, more velvety. The delivery systems are smoother. They're more sensitive to your breathing pattern and style. So that old CPAP that may not have been great even 3 to 5 years ago, it changes a lot as time goes by. And each year there are new things and new adaptations that come out. So if you hated it in the past, think about trying it again if you've been diagnosed. So again, low threshold for evaluation for sleep apnea and treatment as well, because we may mitigate progression of other diseases in the process. So for pulmonary hypertension, in general, we know that it's associated with pulmonary fibrosis, but we don't exactly know what to do with it. We have definitions, as you see, and we suspect it in patients who need more oxygen, who have a diffusing capacity. It's kind of a measure of gas exchange being lower, and signs of increased pressures on the right side of the heart. So what do? We want to make sure people have adequate oxygen. You should know if you wear oxygen or require it, 3 settings: one at rest, one with exertion or various levels of exertion if you're doing vigorous activity like at pulmonary rehab, and then with sleep as well too. We want to make sure you're adequately managed. Low oxygen levels can contribute to pulmonary hypertension, increase the pressure that gradually becomes fixed over time, increase the pressure on the right side of the heart, and ultimately downstream to the belly and the legs, which is why people have swelling when they have heart failure. We want to treat obstructive sleep apnea because when we have airway occlusion or floppiness, oxygen levels take a dip down, and they are also causative of higher blood pressure in the pulmonary arteries and can contribute to those downstream effects of right heart failure. We don't know of any specific approved pH therapy that helps. In the sildenafil trial, it didn't meet its primary endpoint, but there were some markers of improvement of dyspnea. So stay tuned. Hopefully we'll have something better in years to come. Blood clots, venous thromboembolism, 34% higher than the general population. It's one of those things that we want to exclude when people have sudden shortness of breath or worsening in their lung disease. So that's why when, if you're sick and come into the hospital, many times your physician will get a CT angiogram to look for blood clots and make sure that's ruled out, because that can be a silent thing. There are no great symptoms that tell us, aha, that's exactly what it is. It mimics worsening in pulmonary fibrosis, heart failure, pneumonia, a lot of different things. Emphysema. We're seeing this phenotype of a combined pulmonary fibrosis emphysema picture, and about 30% of fibrotic patients may have concurrent emphysema as well too. Again, it may suggest a reduced survival. That's why we want to maximally manage that. And right now we don't know of anything different except saying we have 2 things we want to treat. We usually, if there's obstructive lung disease, think about giving inhalers to help with the shortness of breath, and think about treating the fibrosis as well. Lung cancer can be seen in 3 to 22% of IPF patients affected. And that can vary. Somewhere around 10% is the general number, but there's a 5 to 7-fold increase in developing lung cancer. It is very complicated to treat patients with lung cancer because some of the medications and chemotherapies that we use can be toxic, and they be toxic to the lung. They can affect people's ability to participate in rehab and stay active. That can affect our lung function. And we worry about patients going through surgeries of any kind who have lung disease, especially fibrotic lung disease, because of the risk of acute exacerbation. So we make strategies that work under the circumstances and work very closely with the oncologists and surgeons when we have patients who have lung cancer as well. shooting for the best of all possible outcomes. Don't forget about your mood. This is, when you're dealing with any kind of stressful situation, your mood can have such an impact on how you view that situation and how you overcome that situation. Reach out to your providers, reach out to your family, talk to your primary care doctor if anxiety and depression are impairing you from empowering yourself. Because that's the last thing we want to do. We want you to have not just the physical fortitude, but the mental fortitude to really be able to stand up and fight the fight with the rest of your support group and team. Be sure you understand your disease and what your options are out there. We have a lot of resources that everybody's gone over, but ask questions. It was very interesting and telling. We did a survey with patients when they came into clinic about who was asking the questions, who was driving even to the appointment. And the interesting thing that we found out is that the majority of the time, women, when they were patients, were more engaged, asking questions, taking notes, knew their medicines, more so than men. Interestingly, men were always driving to the appointments. That was 100% across the board every single time. But it's kind of an interesting, I don't know if it's a Southern thing or what, but it's an interesting gender disparity. But it's a point in that can vary. It's not just related to gender, but I encourage you to know your medicines. It should be all up here. Know your disease. This will know your possible options and therapies. I think I'm sort of preaching to the choir here because you wouldn't be here at the Pulmonary Fibrosis Foundation if you weren't already engaged. But take that concept back to your support groups and to other people that may be less of participants, because knowledge is empowering. That's just the bottom line. We talked about rehab and correcting deconditioning as well too. So focusing on pulmonary fibrosis is incredibly important, but focus also on other things that can contribute to shortness of breath, not just during the day, but also at nighttime with sleep apnea. Your physicians are looking for clues in your evaluation for anything else that's low-hanging fruit that may improve shortness of breath and be one of those reversible entities that can really help you do the things you want to do in your day-to-day life. I think that's the end, and we're probably going to move on to questions, but thank you very much.